I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest is a nurse, foremost, with a lot of experience. And one of the things I'd like to relate before I introduce her is that when I was in training as a medical student and a resident, the nurses had a great impact on me and my training. And I remember there's one nurse in particular, her name was Judy Sinclair. She has now passed away, unfortunately, that really impacted my view of medicine and care for patients and what really counts and what really doesn't count. So I will give you a little bit of a story. So it was my first night as a house officer, and in the hospital that I was in, it was about 150 beds. The teaching service was about 30 to 35 patients, but 10 admissions a night, and I was by myself. They had a senior resident on call that I could call if I really needed somebody, but here I am, newly licensed, newly vetted, ready to go, wearing my white coat, jam-packed with my Washington manual, my ACLS training, my advanced trauma life support training cards, and I had it all. Tongue depressors, reflex hammers, my stethoscope. It was just I looked like Batman. So I'm sitting there at the nurse's station on the floor that has all the teaching service, and Judy came up behind me and tapped me on the back, said, "How you doing?" So I'm doing pretty well. Scared to death, but doing pretty well, because it's really the first time I had all the responsibility of patient care without a whole lot of backup, as you do when you're a medical student. So she went away. I started my rounds, and lo and behold, you knew it would happen on the first night. Somebody went into cardiac arrest twice. So went into cardiac arrest in the ED, got admitted to the ICU, and promptly went into cardiac arrest again. So here I am. I'm by myself. The ED is busy. They can't come up. And Judy came up behind me and said, "You've got this. I've watched you for 3 years. You've got this. Just do what you're trained to do. I'll be here to help you." And we took off. Patients survived. I felt real good about myself. But I will tell you, it was her support and the ongoing support of the nurses when I was in training and after I started practice that really, really made practicing medicine a joy. So today we have a guest, Dawn Mattera, who is the Administrative Director of Critical Care and Emergency Department at Holy Name Medical Center. She's been a nurse for 31 years. Congratulations. She's held just about every position a nurse can hold in a hospital: staff nurse, charge nurse, assistant nurse manager, now director level, overseeing the ED and the critical care units. She is a member of the Nurse Residency Advisory Board, Infection Prevention Committee, Patient Safety Committee, Nursing Liaison for Sharing Network, and collaborates with the informatics team, which is what we're going to talk mostly today about. And I'm really proud to have her. Welcome to the program, Dawn.
Thank you. I'm happy to be here.
So, like I said, you've been a nurse for a really, really long time. 31 years is a long time in anybody's book. During this, your hospital started off on building its own EMR.
Correct.
So give me a little bit of your background, your professional background, and then how did you get involved with that project?
Well, professionally, I went to the School of Nursing here at Holy Name, and I've stayed. I've had various opportunities to leave, but I love the organization. So I've been fortunate enough to grow throughout my career here. And I think, especially with people growing up nowadays, I was fortunate to know that I've always wanted to be a nurse. So I truly believe it's a calling. I knew from young as I remember, all in kindergarten, everyone asked what they wanted to be when they grow up. And my parents saved the little book that I had, they made, and I was the nurse, and everyone else wanted to be an actress or a model. And I wanted, the fake stethoscope and bag. So that, it's always been inside of me to do that. And I've been fortunate, like I said, to grow here at the organization. And I think because of that, I've always been a team player. I've always wanted to do best for our patients. Like you said, I've grown in many different roles, with being even preceptors at times and helping with education and fostering the growth of our new staff here, and really seeing how we can benefit and make things better for our patients and for our employees here. So, and I think because of those reasons, I was chosen to be part of this and to collaborate with the IT system and really be our nurse leadership spokesperson to really dive into the role here and really expand this throughout the hospital and to bring it to our staff.
So when you became a part of that team, it was at a very interesting time in our country.
Yes.
The middle of COVID-19. And I think you made the cover of Newsweek, Holy Name did, or Time. I'm not sure which publication. So when you all decided to do that project, I'm just curious about what the decision-making process was to go through and start building a brand new health record during the middle of COVID.
Well, it was really at that time that really shed light that it was, necessary. We're a community hospital, however, we do expand in all different areas and growth. Our ICU is a 19-bed ICU. It's the only ICU in the organization. Our ED holds up to 42 bays, but obviously we can double and move on from that. And when we went from our 19 bed to expand that, at one point we had over 50 ventilators they had to build. I don't know how they did it, but we build, these large ICUs. And at that point, being now at the other hand and helping staff and realizing how difficult it was, because now our patients were, not only did they grow in the amount of patients we had, but the acuity. And they were on massive amounts of drips and treatments that we had to give them. And here we still were documenting on paper, which really made us inefficient. And we needed to be able to streamline that process and see what we could do. We were double, even triple documenting, because a lot of paper obviously doesn't speak to each other either. So we had to I was trying to cut ways out of how we can get to these patients, take care of them, and try to cut out this duplication. So I was really a champion saying, we need to get an electronic. There's a way to do this faster, that calculate even the amount of, for our eyes and O's, to calculate automatically for them for drips and IVs instead of the nurses manually inputting everything. So I think because of that and what we saw and how, like I said, how we expanded so quickly with the amount of patients that we had, that this really was able to go on the forefront to see the need to go to all electronic documentation.
Interestingly, one of the things I have observed about healthcare IT and the industry, and when people start to build things, they almost consider the nurses last, which I think is a horrible mistake, because you guys are with the patients all the time, documenting all the time. But it's amazing, that little tidbit that just doesn't quite hit in a lot of development. So how was it that you got into design and getting rid of all the paper? And tell me a little bit about that process and how that, I know there were several iterations of it.
Well, and that's what's great, because that process is still ongoing. So what we do is, we looked at, obviously we gave all of our paper to show where we can go, like how everything could speak to each other and be put into one electronic area. Certain things do have to be duplicated. Other things, why were we documenting the way we're even documenting? Like I said, I've been here for 31 years and we were still using the same type of nursing documentation from when I started. It was something called a focus charting. So we were just charting by exception, and we were having to put in data and interventions and writing what the response was. And that never changed over the years. And when we looked at this, when they first thought we were going to make the electronic record, they just wanted to duplicate exactly what was on paper to put in electronic. And that didn't make any sense. So I had to bring this to the nurses too and realize this is our time. This is our time to have a voice. Just because that's how we always did everything in the past, this is for us now to make changes and move forward. So, and I think just by having that constant dialogue, including the staff nurses, it expanded from time, having not only the managers in the room and, I was as the director role, but having the staff also have input and being able to see, because the one thing COVID did teach us also is how fluid healthcare is, right? We change from day to day, even sometimes hour to hour, how things were changing. So I think that by having that input from the staff and really being able to make it grow, they were able to make suggestions and make this something that was really user friendly.
So what has that process been like? Feedback and iteration, and we do it this way, but nope, that's not going to work. And then we have to change how we're doing it. Are there any stories from the front lines on how that whole process worked ongoing? Because you said, it was in COVID and everybody was working triple shifts,
right,
to get everything done.
Well, that's how we learn, right? We do something, you learn from. And I think the best part is, I'm able to take constructive criticism. Our IT department, I loved who I work with, but I'd be like, that's a really great idea, but I don't think that's going to work, and I'd have the staff be able to put their input in. And even I'll never forget the first night that we went live in the ICU. The whole IT department was there. They were on site with us. They were making changes as we went along. I'll never forget. And I was amazed how there were certain things that we forgot, whether I forgot, we forgot to put down, if to check someone's wristband, or with something normal that we do, or we just forgot to put a component in, and they were, we could fix that, and they were adding it at that moment and changing it so the nurse was able to document. And then when we did do things, that's not really going to work as well, we realized, and we've gone back to the drawing board. There were things that weren't working as fluently as we thought they would, and we'd be able to go back and they would make changes for us. And we have bi-weekly meetings still, and that's when we meet with some of the management team. I have our champions. We've actually developed our informatic champions for all of our units. They're allowed to have a voice, speak up, and we make enhancements obviously continually as we go along. But if things aren't working, it's the time for us to speak about it and how we can make improvements.
I think that's great. And it's really the way it should be. Well, now that you've deployed it, at least in some very critical parts of the hospital, how have you maximized the use of, you talked a little bit about reducing duplication. I've got to document something here and document something there, as opposed to I've documented it here, I can use it everywhere.
Right.
So how's that process been, being able to take real data and actually save you time and speed up the care?
That's been great. And I'll even say on the first night when the staff was doing their documentation, they're like, I don't know what to do. We're done. They couldn't believe how much time it took off, and that, I can actually go and be with my patient. I can have more time at the bedside. I've been able to provide more of that, one-to-one care at a time with our patients. They were amazed by how efficient they were and the time that they were able to, to continue to be there. So that was a great plus. That was a win for us, definitely.
So can you estimate how much time it reduced in doing the nurse's documentation in the ICU?
At least in half.
50%.
At least, yeah. Yes. And we can do things at the bedside too. We're lucky enough that we have computers in the room. So we're used to multitasking, right? So when you're in there too, you're able to document in the room. Whereas when you had paper, you're grabbing different pieces of paper. And if there was a different, I have to start, a vascular flow sheet now, and now I have to do this. Sometimes, things would happen even during your shift, and you'd have to go out, get another form to fill out. So at least a lot of that is to be able to be done right at the side of the patient now.
Did you have any naysayers when it first started out?
Of course. And I said, let's start it. We're good at having huddles. And it was funny, it was the one thing they loved, because at huddles, they were able to see, especially during COVID, leadership was always there. So I was there for my 7 a.m. huddle, and I was there for my 7 p.m. huddle. And that's how we got staff to keep coming back, because obviously if I'm there, they can be there. So of course, our first huddle, here we go. We're going to start our shift. IT's here with us. We're going to start our, this is, I don't know if this is going to, we didn't have enough class time, or we didn't have enough, this is going to take me forever. And, of course, you're going to have naysayers wherever you go. And that one person who caused the biggest issues probably for me during the huddle, at the end of the shift, came back and apologized and thanked us, because it really wasn't that bad.
That's a great story. I have a couple of those as well. So it's interesting that when you have somebody who really, really is against it and you prove to them that they can actually do it faster, better,
Mhm.
and actually have more fun doing it.
Yes.
And they go, oh, they're best fans of the whole process. So what's your roadmap going forward? You've deployed in the ICU. I think you're in of course, the ED, and then there's step downs.
Right. And then we went housewide, so all med surge is already deployed. The next step is we're going to be looking at our procedural areas and our PACU.
And how do you think that's coming along?
I think it's coming along great. They know it's important. It's important for us to all to be on the same page, especially, there's sometimes there are things that will affect all of our areas. And, we're kind of having to hold back on certain, protocols to put in place or get off paper, like a certain order set, just because we need to have our procedural areas on board too, especially because they're feeders to my ICU and step down. So we need to be able to be having the same type of documentation. So, they know that that's a priority and they're definitely working on it. It'll definitely be done within this year.
Very good. So what was it like? You're a nurse clinician and being involved in the actual, let's do it this way as opposed to that way. And they obviously knee-jerk reaction to everyone. If they go from paper to a product, any product, they want to mimic the paper.
Correct.
Well, tell me a little bit about your input and your team's input into the design of what you actually came out the other end with.
Right. So like I said, just mimicking, I kept telling them a piece of paper. The only difference we're doing then is that instead of actually writing it with a pen, is they're basically typing it onto a computer. So, we want to expand. We want to be, there's definitely more that we could have learned from this. Like, we had to think out of the box. How can we do things to have things interrelated and be able to make, like I said, improve our quality of care that we're giving our patients, be able to get the data that we need appropriately. There's certain things that we can do that we just don't want to duplicate something. So obviously the next thing is we've been able to put, we all have to go by CMS and Joint Commission standards. So there's certain things that have to be documented. So working on having hard stops. So to remind the nurse, oops, I have to document this before I can go to the next, because on paper, it's very simple. You just don't fill out the form or fill out that box. So putting in the hard stops, having things to actually be able to talk you through, like when you're, building on whether we're doing screenings. So the great thing about this is we have these pop boxes. So like if they screen something and it's showing, like say if we're doing a suicide screening or assessment, or even like a CWAP protocol, which we use for our alcoholic patients that come in, there's certain things that pop up. Is this patient at risk by going through having, withdrawal symptoms? And if they are, it brings you to a new pop up and it'll expand and it'll help with assessments to go on and how often you have to assess that patient. We're looking forward for that to be actually integrated into setting off order sets too. That's something for the future that we're working on, which with paper, you can't do that.
So talk a little bit about going unit to unit, because one of the things that I recall, which was a lot of work for nurses, is when folks got transferred out of the ED into the ICU or out of the ICU into a step down or step down to the floor. It seemed like back in the old days, and I'll date myself, a long time ago, they had to redo everything. So
Correct.
have you been able to leverage what you've built unit to unit to unit?
Yes. So right now you still have the ED doesn't feed into all of our inpatient areas yet. But that is something that will, so that we can continue on. So especially if you have like a neuro patient and you're doing your neuro assessments and you want to be able to put that against what you see in ICU, what you see, what the ED saw. So that's something right now. They're still in the ED has their assessment, and then we will have to start a new time. But, that is something that we're going to be integrating, that they're working on, so that we'll be able just to continue on, but that you'll be able to see where they were located. So for our inpatient units, when I have a patient in the ICU, that patient could be transferred out into, say, my step down unit. They'll start, of course, everyone has to start the time that they document someone, when they intake the patient, but you'll be able to see on the bottom, we're able to scroll and see where they were. And what they've done is they've indicated the areas. So like if they did your eyes and nose or your flow sheet that you started in ICU, and then they've gone to our step down unit, it'll say where they were located. So it'll say ICU, it'll say 1 North is our step down. So you'd have the 1 North area. And then there are many times we transfer from our step down to our med surg unit. So you can see the timeline and you can see where they are, and they have the different units that they were on.
So you talked a little bit about this, about JCO, and I'm an old JCO reviewer. Has it really helped in that process in making sure that you can meet all the JCO requirements and how you document that, track it, present it?
Yes, it's helped with documentation. We just recently had a successful Joint Commission visit. It also allowed us to see what we need to build on to make us even more efficient and make the next Joint Commission visit also as successful as this one was. And it allows you, because you might forget, and there's certain pointers, things that need to be done. Like how often you have to assess your vascular access. We have policies. So our policy is that they have to, assess this every 2 hours. It needs to be an assessment. And if that's what our policy says and we're going against it, obviously that would be a Joint Commission finding. And, we've been able to put it in through the electronic record. This is just one example that, they can't move on. They have to be able to fill in their every 2 hour assessment before they move on as a reminder for them. And same with towards the end of the shift, we have to verify our vital signs on some of the units. If the patient care technicians do vitals, the registered nurse has to really be the one to validate them. So there's a reminder for them that, it'll show up in a little red, number that has to be done, and they have to go back to that area and be able to validate all that. So by doing all those reminders and having things, it definitely had helped with us in succeeding in our Joint Commission survey that we recently had.
So when you were designing and getting things, built, was that part of the process as well? Where you took you knew what the criteria that your own policies were going to create?
Yes.
And then you created the EMR to mimic and help provide those. Right. Is that correct?
Yes. And that's why we just couldn't have staff nurses. Our frontline providers, obviously, we want them to be part of this, but sometimes they're not always thinking about the policy and procedure part. So that's why it's important to also have nursing leadership as part of this, just to keep us online and streamline us with that. And I mean, even another huge thing that has helped us, especially in our scorecards, is the reporting mechanism. I can't tell you how often reporting, I was doing manual reports, reading, documenting, with little check marks of how many and trying to keep track of everything. And especially now being in the ED, everything's quality metrics. So it's always about door to provider, left without being seen, everything's timed. The difference of having an electronic medical record and be able to pull this data out has been wonderful. It's helped us in all of our, performance improvement projects. It's easy for all of us to get data. We do monthly scorecards now, and we're able to get everything that's important to the certain areas, and we can, get reports. We work with our data analysis team, and they help us get those reports. I can ask for a report now, and they'll develop it, and they'll be able to pull right off our medical record.
So I have to ask this: if you had it to do over again, would there be anything you'd change, or would you say, I ain't doing it? It was a bad project. Wrong time. Let's delay it. What's your comments on that?
I was happy. I was part of it. I'm happy I'm still part of it because we're still growing. So, obviously you'd like things to be done, everything to be done at once. But I think by doing it sometimes in pieces like this and being able to see how you can grow, because it allowed you to see what was working and what wasn't. So if we threw everything all together at once, because we're still adapting and making changes, I think by doing it this way has really allowed for us to see what we're doing good and where our opportunities of improvements are.
So we're kind of coming down to the end of our time here. I ask this question of everyone I interview: is if there was one thing you could wave a magic wand and change, what would that be in healthcare?
The one thing I would change actually has nothing to do with computerized documentation system. What it has
it's an open-ended question.
Yes, is obviously our national shortage of staff, and it's not just nursing. Nursing is one of them, but our providers, all aspects, our phlebotomist. It's everyone. I wish that there was more people to see. There's a need here. And healthcare, obviously there's many different roles. You could be a nurse and you didn't have to work in a hospital, but you'd still between wellness and settings on the outside and anything. I just wish that we had more of a group of individuals now who'd be able to join into healthcare with us and see that this is a great profession. It's honorable to be able to serve others. And I just wish that we had more people, influx of people coming into the profession right now.
That's a very, very good request, as several of the people I know are in nursing faculty, and I used to teach at a nursing school when I was doing my graduate work. So it's a really great request, because we do need more providers. We need more trained people to do the work. Well, Dawn, it's been a pleasure. If someone wants to get a hold of you and ask you questions about what you did, how you did it, and maybe learn a little bit more, how would they get a hold of you?
They can contact me by email. I can give you my email address.
You can go ahead and just tell the audience your email, and then we'll
D,
make sure it's posted.
Okay, it's D Mattera, Mattera @holyname.org.
Dawn, thank you so much for being on our program today. It's a pleasure to talk with you, and I'm very excited about what you guys are doing at Holy Name.
Thank you. Thank you so much.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp Systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.